Hi, I'm Dr. Darren McGuire, cardiologist at UT Southwestern, and it's my pleasure to present the primary results from the sole randomized trial of oral semaglutide in people with type 2 diabetes and high risk for atherosclerotic cardiovascular disease on behalf of my executive committee, the trial sponsor, and the participants in the trial. So oral semaglutide was formulated to overcome some of the clinical resistance to taking injections. We've seen a number of positive randomized clinical trials with injectable GLP-1 receptor agonists favorably affecting cardiovascular risk. These have entered the product labels and the guidelines for cardiovascular care, but it's estimated roughly half of patients who have access to an indication for the injectables are not taking them just because of the injection part of the therapy. So oral semaglutide was developed to overcome this clinical unmet need. So we randomized 9,650 participants with atherosclerotic cardiovascular disease or chronic kidney disease who had type 2 diabetes and age 50 or greater. Our primary outcome in the trial was cardiovascular death, MI, or stroke. Patients were randomized to get placebo-controlled oral semaglutide starting for 4 weeks at 3 milligrams, titrated at 4 weeks to 7 milligrams, and ultimately 4 weeks later titrated to the target dose of 14 milligrams once daily of oral semaglutide. This is the dose that's presently approved to treat hyperglycemia in type 2 diabetes and also has a previous trial demonstrating cardiovascular safety, but not efficacy. So the sole trial was to take that one step farther to test for superiority of oral semaglutide versus placebo on cardiovascular outcomes. Our primary outcome, as I mentioned, was time to first event of cardiovascular death, MI, and stroke. Our prioritized secondary exploratory outcome was a 5-point composite outcome of kidney-related outcomes, followed by cardiovascular death, and subsequently a confirmatory outcome of major adverse limb events, which we defined in the trial as hospitalization for acute or chronic limb ischemia. We did a number of exploratory analyses of the individual components of the composites, of inflammatory markers, and of metabolic parameters. This is the disposition. We had perfect balanced randomization of 9,650 participants. Over 98% completed the trial. And those stopping study drug early, represented at the very bottom of the trial, was higher in the placebo group than it was in the oral semaglutide group, underscoring the tolerability of oral semaglutide, and this reflects most likely the fact that hemoglobin A1C was being monitored and managed in an open label fashion. People in the placebo group were coming off investigational products so that they could be treated with open label GLP-1 receptor agonists. On average, patients were 66 years old, 3/4 were men, average A1C was 8%, BMI was 31%. These individuals in the trial had an average duration of diabetes of 15 years. And the ASCVD and EGFR representation is at the bottom of the slide. EGFR on average was 74. High sensitivity CRP at study entry was 2, right at the normal threshold or abnormal threshold. And importantly, over a quarter of the patients were being treated with SGLT2 inhibitors at study baseline. And during the trial, an additional 25% were started on SGLT2 inhibitors. So we have an exposure of 50% of trial participants getting SGLT2 inhibitors on top of the randomized placebo-controlled oral semaglutide. The primary outcome, cardiovascular death, MI, and stroke, occurred about 14% over a 54-month period of time in the placebo group. This was reduced with oral semaglutide by 14%, statistically significant 14% reduction, hazard ratio 0.86. So the primary outcome of the sole trial was positive. And I'll remind the audience that the 0.86 hazard ratio is exactly the hazard ratio from the pooled analysis of previous injectable GLP-1 receptor agonists, so putting oral semaglutide squarely into the class effect space of GLP-1 receptor agonists for cardiovascular risk mitigation. Our prioritized exploratory outcome in the hierarchy, 5-point major kidney disease, that was cardiovascular related death, kidney-related death, EGFR reduction greater than or equal to 50%, persistent EGFR less than 15%, or chronic kidney replacement therapy, was directionally favorable, a point estimate of 0.91, but the confidence interval crossed unity. The p-value was not significant, and therefore all subsequent analysis become exploratory. Cardiovascular death alone, again, directionally favorable, but again, not achieving nominal significance with confidence intervals crossing unity a point estimate for cardiovascular death of a 7% risk reduction. Interesting, peripheral arterial disease events occurred less commonly in those taking oral semaglutide versus placebo. The curve separated relatively late after 24 months, but continued to diverge through the rest of the trial. Again, this is a composite outcome of hospitalization for acute or chronic limb ischemia. So the confidence interval here excludes unity, a point estimate of a 29% relative risk reduction, raising the hypothesis that oral semaglutide reduces PAD-related events. Supportive secondary outcomes across the individual components of the cardiovascular composites all were directionally favorable, as you can see here, fairly consistently across the spectrum of outcomes analyzed, supporting the generalizability and the broad spectrum clinical benefits of oral semaglutide across cardiovascular risk outcomes. Subgroups pre-specified, stratified by sex, age, BMI, A1C, EGFR region, and SGLT2 inhibitor use at baseline were all fairly consistent directionally. There is some statistical interaction by region, where in the North America region, there is less effect, as in Europe as well, but Asia and other regions driving that result. We think that probably has most to do with adherence to investigational product and not because of differential efficacy by region. We were concerned about this oral formulation of semaglutide getting actually pharmacodynamically effective doses to the patients. This is a unique tablet that has to stick to the gastric mucosa, should be taken on an empty stomach with less than 4 ounces of water and with no oral intake for 30 minutes. And so we weren't sure if a patient population of 10,000 people could actually do this over a period of 4 to 5 years. And we actually demonstrated that, in fact, they could. Hemoglobin A1C was reduced, body weight was reduced, CRP was reduced, as is expected with GLP-1 receptor agonist therapy. And so these biometric parameters reinforce the fact that the patients were actually able to take and get a pharmacologic dose of the semaglutide with the oral formulation. So in conclusion, oral semaglutide was superior to placebo in reducing the incidence of 3-point MACE, that's cardiovascular death, MI, and stroke in people with type 2 diabetes, with atherosclerotic cardiovascular disease and or chronic kidney disease. There were consistent cardiovascular efficacy of oral semaglutide across subgroups by sex, age, BMI, EGFR, and concomitant medication. The overall safety profile of oral semaglutide in SOUL was similar to that observed in previous clinical trials with semaglutide, and no new safety signals were found. The trial results add to the favorable benefit-risk profile of oral semaglutide in this population. And I'll remind the audience, the point estimate of efficacy for 3-point MACE of 14% relative risk reduction is exactly what was observed in the previous pooled analysis of the injectable GLP-1 receptor agonist, putting oral semaglutide squarely into the GLP-1 receptor agonist space. This is the only oral formulation of GLP-1 receptor agonist that has cardiovascular efficacy proven. It's not yet product labeled, but the regulators will be reviewing these data, and we fully anticipate a product labeled indication for cardiovascular risk reduction that will parallel the previous GLP-1 receptor agonist. So thanks for the time, and I appreciate the opportunity to present these data.
Excellent. All right, so now that we're back to the panel, let's go to the question that was brought up by the person in the audience. What do you think the mechanism is? Does anyone want to start off and guess? I have a few thoughts myself, but what does everybody? Let's do it this way. Does anyone have a thought as to what the mechanism of benefit is? And I guess I'll start this off by saying, Marc, was it all weight loss in STRIDE?
Yeah, I was going to say we could start saying what it isn't. It's not glucose lowering. We know that both for the MACE benefits and for the limb outcomes. Darren can speak to this. He's one of the world's experts in this area, but certainly for the functional outcomes, the glucose lowering was modest, and other glucose lowering drugs don't do this. It wasn't weight loss. Weight loss is part of the story. Actually, we're presenting data at the ADA. It is true that if you have a very motivated patient who loses weight by exercising, they will also walk better, because exercise makes you walk better. The weight loss related to semaglutide was very weakly correlated, so it wasn't that. I think we can all talk about different potential mechanisms, but I strongly suspect that anti-inflammatory effects play a key role here. So I'll let others sort of comment now.
I'll take on where Marc left off, and I think the anti-inflammatory effects of these drugs are pretty profound and pretty acute, and we've seen in other GLP-1 receptor agonist trials that ASCVD unstable events are affected acutely. It's not like the LDL modification where we have to marinate in the new LDL for a year before we see the curves separate. So I think that's probably it, but I will take one step back. And for the clinicians who are asking what's the mechanism, I would say, who cares? I mean, if you have different clinical outcomes with one therapy versus the other, we don't need to care about the mechanism as much as we need to get the therapy prescribed. The how and the mechanism informs further research if you want to target novel therapies, novel targets. But I lecture on this all the time, and I get quite frustrated when people, if they don't understand how, they're resistant to prescribe the medicine. And I will remind you that SGLT2 inhibitors and empagliflozin at the FDA meeting, every one of the 8 endocrinologists voted not to approve empagliflozin because they didn't understand the mechanism. It's like, we have to let the mechanism go and let the scientists figure that out, but at the same time in the clinic prescribe the medicines proven with clinical efficacy.
I think I will say this. I think there's 2 separate issues here. One, I agree that demonstrating that it works in a large randomized trial is enough to verify and substantiate its use. Understanding the mechanism actually helps people use the drug, as you can tell by the weird response by the FDA panel, but also by other people we just speak to. It also helps us figure out how to move forward on different trials. Like, I think the understanding, and this is heresy where I work, but the idea that statins reduced inflammation at the time of an acute coronary syndrome really pushed anti-inflammatory science and then therapies forward. Now, for GLP-1 receptor agonists, we published a study using liraglutide where we also had a weight control population and a DPP-4 population. And this was the only drug that improved endothelial function in patients who had insulin resistance. GLP-1 receptors are actually found on endothelial cells and vascular smooth muscle cells. And there was a small trial recently that demonstrated that the use of these drugs improved TCPO2 in patients with severe PAD. So there may be also a microvascular benefit as well as a large vessel benefit. I don't disagree with anything that anyone said. Trying to understand how they work will maybe help us move to the next kinds of therapies. And it's not a comment on whether we should use the drugs. But I think understanding the mechanism also helps us understand what's going on disease-wise with our own patients. All right, so we went through and we had a conversation about how needles make it more difficult to give the drug to patients because there's more friction both from docs and from patients. And even though it's actually not that difficult, that does not, it's also not difficult to give statins. And I have patients who apparently access the internet who think that those drugs are poison. So do we think that having an oral version will make a significant difference? Is it going to be easier? And I'm going to ask the folks who've been relatively quiet. So Daniella, Tino, and Brian, would you be more willing, and do you think the conversation would be easier to give these medications orally?
I think it depends on the patient. I think the downside with the oral is this delay between taking the drug with a small amount of water and then being able to eat. Although it was reassuring to see that so many patients were able to do that in the study. But it's going to have to be on an individual basis. There's some patients who would prefer to take the weekly injection and not think about it all week. I don't know. I do think back to our earlier discussion, part of the reason why these drugs are underutilized is people feel like it's not my organ. Clearly, we have the data to show it is our organ and all of our organs. But at minimum, if we're not going to prescribe them, I think these medications should be making it into our note and recommendations for the providers to implement for our patients if we're not going to do it in the office at that time.
But I'll push back a little bit. Why would you not do it in the office? Do you defer statin prescription to other providers?
Not at all, no.
I mean,
but
these
I
are
do
these
think
are
that
cardiovascular medicines. These are cardiovascular medicines. They
you're
have to
not
be part
wrong.
of our everyday practice,
I agree with
right?
you, but I also think when patients come in with a myocardial infarction and get a stent, the primary care physicians or look at cardiologists say to do with DAPT, for example, and follow that. So I agree with you. I think that we need to be prescribing that, but in addition, or if you're not going to be comfortable prescribing it, it needs to make its way into your plan so that people realize that that's the recommendation and that's what should be happening.
Yeah,
I
I
think the
don't buy
heart
that.
failure.
I don't think it makes it into your plan. I think it makes it into your prescription. And I don't. I'm sorry, Josh knows me. I'm very controversial, but it stuns me that we're 10 years out from the data and our cardiologists are not prescribing these medicines. These are not for the primary care. These are not for the endocrinologist. These are cardiovascular medicines, and not prescribing them is like not prescribing antiplatelet therapy or a statin. These are our
Yeah,
medicines
I
as
agree with you,
cardiologists.
Darren, but I don't disagree with you, but I'll say one of the things the heart failure docs have done really well is to demonstrate that starting these medicines in the hospital, for example, when you meet patients there, they're much more likely A, to get them, and B, to stay on them. That kind of data is there for DAT. That kind of data is there for statins. And I would say the next threshold to really get these medications into patients is that anytime they're in the building, for whatever purpose, we should demonstrate that using them there has a significant benefit. B, it's not, you shouldn't avoid starting them in the more acute situations. And B and C, if someone goes out of the hospital on a medicine, they're much more likely to be on it, A, in a year, and B, their primary care physicians will see that it's tied to these events. I think that our implementation of the data has been poor. And I think part of the reason, as we talked about before, was that it was all needle based. And I think that was really hard to get people to give, even when they have never given any other needle-based therapies until the PCSK9s. And we can see how well those have been taken up. That's taken a while also. I think we are changing over things now. I think people are becoming far more comfortable, as our prescribers are on these drugs and can just attest to the fact that, actually this is not really a big deal. It's probably easier just to take a once a week or once every other week medicine.
Yep.
But I
was
will
going to
tell
say
you
that.
yeah, I think that I think that there's a lot of, I think there was a lot of friction because it was a needle-based therapy, not because they didn't want to give it. Also, and I don't disagree, the guidelines, yes, I think all medical information is ahead of the guidelines, but you can see what the PAD guidelines said in 2024. It didn't get a class 1. Even it did as a diabetes therapy. But Select would suggest you don't even have to have diabetes to get a benefit from
Right.
these drugs for
That's a
naturally. So, yeah.
that's a
So
guide.
I
That's a
think that,
guideline writing committee I want my money back from. In 2024, the data were so ample. Why is that? But here's the deal for the injection. Let's be clear. It's a 35 gauge needle. You cannot feel it enter the skin. You don't need to alcohol swab. It is the fastest, easiest administration. And even though I chaired the SOUL trial of oral semaglutide, it should be injectable every time. And there should be no resistance.
all
You
right.
can't feel it enter the skin. I mean, it's comical how people are so resistant to this injection therapy. And since for 20 years, the World Health Organization has discouraged alcohol swabbing for small volume injections, so you don't even have to swab the skin. Bare skin, stick it in, you're done. It's 30 seconds.
Yeah.
So the
I
fact
don't think
that
anyone disagrees. I think we have to teach people how to do it. Let's, as we're coming closer to the end, let's let some of the other folks jump in. Brian, Tino, Sahil, Daniella, tell us where you're going to go from here with this data.
I had a question before I go there, and that is, do we think because it's tied as a weight loss medication hurts us? Does that hurt us to get it approved? Does it hurt us to get it from the insurers, to get it on the guidelines? to make it accessible?
So actually, for
I'll just make a
diabetes,
comment.
it's not that hard.
No, I'll just say I think how you write the prescription and what you write for does impact whether it gets covered. And so you have to be careful. Like, it's covered for diabetes, as Darren said, it's covered for actually the select criteria. We get coverage for that. If it's written for obesity, it doesn't get covered. And so one thing I think that is a barrier, and Sahil made this point, is coverage. And one thing we can do together is sort of share language of like, what do you need to put in your note and how do you write the script to get it covered? Because it actually makes a big difference in terms of what you're facing after in terms of prior authorization stuff. I also wanted to comment, a lot of people are prescribing PCSK9 injectables without an issue, I think more than this drug. And so I don't think it's just the injection. And I want to be fair that I do think these drugs were rolled out as diabetes drugs. I mean, they're not, but that's how they were sort of initially studied and rolled out. And, in our own institution, there was a lot of, with the endocrinologists, like, well, be careful if they're on insulin too, because you have to adjust the dose. There was a lot of this sort of, I think, fed into this, hey, let us deal with the drug class. Now, this is 5 years ago. I mean, Select, I think, changed everything, and now Sol and Stride. But I do think there's a legacy of how these drugs were rolled out that has made it harder to implement in the cardiovascular space.
And to add to that, there's
All right,
a
does
lot of
anybody want to
people
say
who
anything?
are.
No, go ahead. Sorry, Danielle, go
I
ahead.
was just
Sorry.
going to say that's okay. No, there's a lot of people who are the sole vascular provider for patients who are not cardiologists, who are vascular surgeons or interventional radiologists, and may not necessarily, I guess that's a lot of where my comment was coming from. I don't think you're wrong. I think that it's an easy drug to prescribe, but, any change is difficult to make, and there's going to be a lag time. I think with this data, we have a lot of reason to implement these therapies now right away.
All right, Brian, Brian or Tino, you're gonna get the last comment.
Yeah.
Go for it.
Well, I would say the same thing. I remember when we started writing, statins, and when we started writing rivaroxaban, it took a while to get us going. But I think the data is there, and I think there is a strong reason that as we see these patients, especially those patients that we see that may not have that many other providers or that may see you as their primary provider, how it's important to get the word out, get it, start prescribing it, and let the other physicians know, or potential physicians know, why you're doing it, and get things going. And I think that's how you start the movement.
Agree. That sounds great. We are now a couple of minutes over. I want to thank everybody for participating. This was a really great conversation. We had a lot of active and interested viewers because of the quality of our discussion. I think we can skip the slides. They're not necessary. We covered every one of the topics that we asked people about. The one thing I'll say is that we have a lot of therapies now that can improve limbs as well as lives. And as you heard the data tonight, I think we should start to we don't have to wait until 2040 to get our stuff in. We should probably do it next week. And with that, I'll say thanks to our presenters, thanks to our panel, and thanks to you for coming. From headquarters, thanks for coming to the Data Deep Dive. Have a good night.
Good night, everyone.